Okay, welcome everyone to the practice cases. Now we have a 55-year-old male who presents with a black colored stool.
Mm.
Let's look at the vitals. Vitals blood pressure is 100 over 60 supine and 80 over 50 sitting. Heart rate is 124, respiration 24, temperature is 98. So when you have this condition, now the history. Let me give you the whole history. Sorry. So he presented to the emergency room with 6 episodes of black stool over the last 24 hours. He decided to seek medical help after he vomited bright red blood about an hour ago and felt weak, lightheaded. The patient has a history of epigastric pain for the last month that cover mostly on an empty stomach and relieved with food and antacid. He has chronic low back pain and taking over-the-counter ibuprofen on a regular basis. The patient has smoked pack of cigarettes, so you gotta counsel him on smoking. And he drinks beer socially on weekends. So he's smoking and beer. We counsel him on that. And he's 55, so he would need colonoscopy, and that's about it. Lipid profile. Yeah, that's about it. Okay. Now let's go. It's his emergency room. Okay. So what do you want to do?
So I want to cancel his ibuprofen.
Yeah. Perfect. Let's see. Yeah,
Um,
we canceled that already. Okay. What else?
I'm going to do a, I guess, the vitals and oxygen and give him IV fluids because his blood pressure, he has orthostatic changes.
Okay.
Um, yeah, and then I'm going to do a quick physical, focused after all of that. Cardiac BP monitor, all that, yeah.
Monitor. BS finger sticker. So this police. I did the police. And then let's
Sure.
do CBC CMP with it too. Okay, so
We can do H and H alone.
yeah, that's a good idea.
Because if he's really low on hemoglobin, we probably need to transfuse him too. So you need to do type in screen and all of that. So yeah, let's do a quick physical to make sure he's not having like maybe they'll give us some clues.
Yeah, you're right. Yeah. CPC, I'm gonna put it every 24 hour. What's going on? Okay, every one day.
Now the fact that he has black stool means
Yeah,
he has a upper GI bleed.
yeah. So let's check the
And the most
heat.
common cause of upper GI bleed is peptic ulcer too.
Yeah, maybe we need to put him on omeprazole. Let's see. So now, do
Mm.
you want to examine anything else? Rectal. Let's do it.
Yeah, rectal for sure.
What else? Yeah, that's about it. Let's see. He's lightheaded. No neuro, maybe. Not important. Okay.
So what are the positive findings?
Okay, let's see. Let's show up. Okay, now, yeah, the physical examination finding. He's a 55 and his stated age is pale, mildly anxious, pale conjunctiva, anecteric sclera, lung clear, heart tachycardic, abdomen is soft, mild tenderness in the epigastric area, rectal, normal sphincter tone, and no edema or no cough tenderness, peripheral, pulses are fine. So that's about it. There's not much positive, just pale conjunctiva. So it's anemic, tachycardic. That's
Okay,
about
let's
it.
have
No, the hematocrit hemoglobin. That's important.
yeah, we have to see the H and H to make sure he doesn't need transfusion.
Hemoglobin, hematocrit.
And let's get some results and then we'll see what's going on.
Okay. Now
Can
let's
we
do
do
let's do
any
other.
oh sorry.
Yeah, let's do other. So I found a mnemonic. It's very good one. It covers everything. It's called CBC, LFT, lipid profile. Let's check the HHNH first. Sorry. Let's get the
I'm
HNH. You're right. Let's get the HNH first, and then we'll do the other less important. Okay, boom. The hemoglobin is 6.9.
Alright, I'm gonna quickly stop, do type and screen, cross match, PT, PTT, INR, whatever, and then I'm going to pack RBCs, transfusion,
Let's consult GI.
console GI, and
Let's do EKG too. The lipid profile. That's an additional magnesium, phosphorus, ESR, FOBT. Let's check stool, thyroid. It's not important. That's how you can do that. We do abdominal X-ray. Okay, just X-ray, just in case. Air under diaphragm will show up here. What else? Do you want to do anything else?
yeah, transfuse blood, pack RBCs.
Yeah, that's true. That's true. Yeah, packed out of the cell.
You should do his orthostatics too. Like, did you type in orthostatics?
Let's do amylase. Orthostatic.
Mm,
Let's do Now we're good to go. Let's see.
mm-hmm.
Type and screen.
Yeah, anybody less than well, there's an exception. If it's less than 9 for a cardiac patient, like a CHF, you need to transfuse them if they're less than 9. Less than 7 is for general population.
Yeah, you're right. Yeah, I think it's 8. If it's 8 and with a cardiac issue, then you transfuse him.
Is it 8 or 9? 8, I'm sorry. 8, yeah.
I think it's 8. Yeah.
Yeah, I think you're right.
That's what I read the other day. If I'm not demented, I hope. So that's the stool. What do you want to do?
Stool, did you do stain and...
Would you like to do GAIAC?
Sure. Did you order his UA by any chance?
No, I'll order it. I forgot. Right.
Would you do a urea breath test on him? I'm just saying.
No, I don't think there's need for that.
Okay. So basically, he just came in for acute blood loss because of GI bleed, and he needs to transfusion, right? That's this case.
Yeah, you're right. Now we admit him to the inpatient. Let's just admit him to the inpatient, and then we order like the V panic, which is vitals.
Yes, vitals.
Omeprazole. Panic, bed rest. Okay. Pneumatic compression.
No. N for NPO. NG2.
Yeah, NPO, yeah.
I for
NG-tube, yeah. What else?
and output.
Panic, input, output, yeah. Yeah, this. And then we do hemoglobin and hematocrit every 6 hours.
Yeah.
So important. And then we do PT and INR also after transfusion.
Yes.
Yeah. Do you want to do anything else?
Not that I know. Just put in a UA. You didn't put in a UA at all.
Yeah, I'll put
just so you get points for that.
Yeah. This one should be IV, but that's okay. Yeah. We'll do. So bed rest.
We need to cancel him. We have to do no smoking, no alcohol, colonoscopy, vaccines before the case ends.
Yeah. We got 19 seconds.
Yeah, see, you were doing 20-minute cases. That's why it took us so long. We should do 8 minutes. Even if it's a 20-minute case, we should still be able to do it in 8 minutes, no matter what.
Yeah, yeah, you're right. Yeah,
So
yeah, we're
I think
discussing this.
now,
Now
yeah.
let's just cancel and yeah, basically that's it. Like you just observe him overnight, like 1 to 2 days,
Hmm.
3 days, and think you should be fine, like in 1 to 2 days.
Yes. I think the key here was we had to stop his ibuprofen.
Yeah, that's an important one. Yeah, that's stopping ibuprofen. That's an important one.
Mm.
So how do you summarize this case?
So we have a man who has black stools, right, presenting with orthostatic changes, really low blood pressure, tachycardic. So first thing we need to rule out is that we have to check his hemoglobin and hematocrit to make sure he didn't bleed out too much for him to become unstable and go into cardiac failure. So we need to once we check that, we have to order blood transfusion for him, and also stop his ibuprofen first. So this way we know we manage him, stabilize him, and then check his H&H every 6 hours. And you know, um, basically that's it. That's what this case was about: managing acute blood loss.
Okay, so
We
the
don't.
main management is that termination of the bleeding and resuscitation. So if you
Mhm,
start with two large peripheral catheter and supplemental oxygen if needed, this
mhm,
immediately, and then you give him isotonic crystalloid solution.
mhm,
That's the initial treatment. So for the blood transfusions, if it's less than 7, in low risk patient, less than 7. But high risk patient like acute coronary syndrome, it's less than 9.
so it is 9,
Yeah,
right?
it's 9. Yeah, you're right. Yeah. So it's 8. Yeah, I mean if it's 8, if it's 9, you don't transfuse him. But if it's 8, you transfuse him. That's it.
Oh, I see.
Yeah,
Gotcha. So okay.
yeah. If hemodynamic instability despite appropriate crystalloid resuscitation, okay, then you give him a transfusion. Okay,
Yeah.
and the
Mhm.
patient should not be given anything by mouth. So it's good put him on NPO, and
Yeah.
you give him IV pantoprazole, esomeprazole.
Mhm.
So when you write omeprazole, it's gonna show only oral, I think. But if you write pantoprazole, it's gonna show you the option to IV.
I see.
Okay. And you gotta start him on octreotide. This is very important.
Why octreotide?
If only if there's cirrhosis or varicose bleeding.
We don't even know the cause of bleeding. We didn't even do
Yeah,
any.
yeah.
We did an X-ray, but we didn't
No,
find anything.
no, no, not for this guy. Only not for this guy. Not guy. But if the cause of bleeding is the cirrhosis or esophageal varices, then you add octreotide.
Oh, yeah, yeah, yeah. Or beta blocker.
Yeah, yeah. Beta blocker. So if it's for preventative.
Oh, okay.
Yeah. NG tube. When do you use NG tube?
Um, MG tube is when anybody has a GI bleed, right? Like you want to suction the stomach to see if the blood comes out from the stomach or not,
So
right?
is considered if the blood clot need to be removed to facilitate endoscopy. Then you do that. Okay,
Oh,
and you gotta consult GI.
mm-hmm. Yes.
Okay. How about a stable patient without severe bleeding or high risk stigmata? What should we do?
Well, stable patient meaning vitals are fine and a positive blood on in stool.
Hmm? Yeah.
I would do. I would set him up for a colonoscopy, or actually not colonoscopy. Sorry, endoscopy, because you can only do endoscopy on stable patients.
Yeah. So when you have someone who's stable, you can discharge him on oral omeprazole and you just follow up with him.
Mm-hmm.
That's the thing. But if someone with active bleeding or adherent clot should continue IV omeprazole for 72 hours following endoscopy
Mm-hmm.
if there is active bleeding. But
Okay.
if there is no signs of bleeding, then you switch him to oral PPI.
Mm-hmm.
Okay, And all patient with with PP of peptic ulcer should be screened for what?
H. pylori.
Yeah, perfect. Yeah, screen for H. pylori, especially if they are not using non-steroidal anti-inflammatory drugs.
Mm-hmm.
Okay, so that's the thing. Okay, so
Mm-hmm.
let's go to the next one then.
Do you think you can come closer to the mic a little bit when you talk? Because your voice fades away sometimes.
Oh, sorry,
Sorry, but like,
sorry.
yeah, just
No. Yeah, that's okay. I'm using my headphone now.
oh,
Okay,
okay.
yeah. So let's see. I think let me. How did you show the diagnosis last time? There's another
View,
case. Better
view.
toggle diagnosis. Okay.
If you want it in alphabetical order, you click the diagnosis.
Hmm. Yeah, that's good.
Yeah.
I think that was
Like,
that was a good case last time.
mm-hmm.
Okay. Okay. So now this patient present with a bright red blood per rectum. He's a 67. She's a 67, 65-year-old female. Okay. Vitals BP is 100 over 70 supine, 80 over 50 sitting. Heart rate is 120. Respiratory rate is 24. Okay.
Mm.
Now this patient, she's a 65, comes with a due to 3 episodes of passing moderate amount of bright red blood with a stool over the past day, and she has been feeling weak, lightheaded, but report no nausea, vomiting, or any other abnormality. She has no hematemesis, melena, diarrhea, or anything else. Her past medical history is significant for type 2 diabetes, hypertension, hyperlipidemia. She never had a colonoscopy. Her medication, she's taking gluperide, simvastatin, lisinopril. Her mom died of colon cancer at age 60. The rest of symptoms are fine. So this, by just having her like 65, we need to do DEXA, mammo, and colonoscopy. Okay, and then we counsel her on alcohol and smoking if she's a smoker or anything like that. But looks like she's not a smoker or anything, so that's okay. So now, so far we gotta keep this in mind. This screening vaccine, maybe we give them pneumococcal vaccine and influenza. This is just to keep in mind. Now she doesn't have any pain or anything. Okay, so let's see. She's in the emergency room now. Okay, so what do you want to do?
Same thing. Started on IV fluids, NPO,
Yeah, let's do
um,
pulse
vitals,
ox,
pulse ox,
oxygen,
oxygen,
IV
all that stuff.
access, IV fluid, cardiac.
BP
What is it?
monitor.
Police. Okay, yeah. Cardiac monitor, BP monitor,
And keep her NPO right now.
hunger sticker, glucose. Yeah, put on NPO. Let's
And
put
my
CBC, CMP, huh?
differential right now is diverticulosis or diverticulitis. But after I do a physical, how many? So she has bright red blood cells. Does she have abdominal pain at all?
No, just a moderate amount of bright red blood for rectum. She's feel weak and lightheaded. So when you have a weak lightheadedness, what it could be? Do you think the angiodysplasia or diverticulosis?
Yeah, angiodysplasia could be there, but that's in males mostly.
Yeah, it doesn't cause lightheadedness. Angiodysplasia usually, and it's not bright red. That's the difference. Okay,
Can we do
so
a
now let's
quick
do a quick
focus?
physical.
Physical appearance, heart, abdomen, rectal, and neuro, maybe. I don't know.
So examination shows pale conjunctiva. Everything is clear, abdomen is fine, no rebound, no guarding. Okay, she's pale looking. Tachycardic. That's it. Rectal is fresh blood in the rectum. No hemorrhoid or fissure or anything like that. Okay. So that's the vitals.
Let's order orthostatics on her 1, 2, H&H,
Orthostatics.
3, abdominal CT. I wanna get a CT result.
Hemoglobin, hematocrit, CT of abdomen, lipid profile, what else of OBT,
You can
amylase,
do
stool,
yeah, urine, UA maybe just.
ESR, urinalysis, yeah.
You can do TSH. Let's do the TSH, magnesium, phosphorus, whatever, everything. EKG. Did you do an EKG on her?
Let's do an EKG now.
I think that should be fine. I need CT results like now.
Okay, no, it should be fine.
When is the only time you do abdominal CT with contrast?
Like if there is a tumor,
But how do you know there's a tumor?
like if someone present with fatigue and you ordered urinalysis, you found hematuria, and the guy is old, working
Like
in a
renal cell
factory,
cancer?
yeah, renal cell carcinoma, then you do it with contrast.
What about bladder cancer?
Yeah, also with contrast, yeah. Usually,
Also,
most of the time with contrast. The only time we don't do contrast when you're in the brain and you're afraid of hemorrhage or worse, or you confuse between the blood in the brain and the contrast.
so now when you ordered an abdominal CT, you did it with contrast?
Yeah, you can do it with contrast here too.
Oh. I never do with contrast. Is there something wrong if I do it that way? Because
No.
chances are, if the creatinine is high, I'm
Yeah,
going.
that's another thing. Yeah, if the creatinine is high, you gotta be careful. Even if the creatinine is high, like in actual practice, they give them IV fluid,
Mm,
and they should be fine with contrast.
mm.
Let's do NG tube and
Oh, you didn't do NG tube yet? Okay, yeah, NG
yeah,
tube.
PT
Mm-hmm.
PTT and forgot the NG tube PT PTT INR type.
Type in.
Yeah, let's do those.
I'm getting really nervous
Why?
because my exam's in 10 days.
Yeah, that's normal feeling. Yeah, everybody will be nervous. Yeah, it's a tough exam. It's annoying. You have the right to feel nervous. It's
So
everything.
how do you feel about my CCS?
Actually, it's good. You're really good at it. I think you're easy pass. You should be able to pass easily.
Like you're saying the truth, right? Like you're not gonna hurt my
No,
feelings.
no,
I was
obviously, no,
honest.
no. I'm straightforward. I'm not flattering you or anything. That.
Okay.
Yeah, but you're ready. I think you can easily pass. Are you looking for a score or
No,
you
not
just want to
really.
pass, huh?
Yeah, I mean, I want to do at least a little bit above average or average. I don't want to do below average.
Yeah,
Average is like 220, I think.
yeah, 225 something like that.
225, yeah.
Yeah, yeah, yeah. But you can pass easily. That's the thing. Okay, so the hemoglobin is 6.9. What do you want to do?
Oh my god. Okay, let's transfuse her. Same case as the other guy.
Uh,
I just hope on the test they don't give me a transfusion reaction because I wouldn't know what to do.
yeah, that would be messed up. Yeah. Yeah,
like
just
stop.
stop the transfusion if
That's it,
there's a
right?
reaction. Yeah, and just hydrate them.
Yeah.
So this is lightheadedness case and stuff. Let's just send him to the ICU.
Mhm. Now we do the ICU mnemonic.
What is it?
It's panic.
Yeah, the same inpatient. Yeah, okay. Vitals.
Keep
Omeprazole.
vital, omeprazole, activity bed rest
Uh,
with privilege,
yeah, panic,
um,
NPO, panic,
NPO,
input, output,
output, C for compression, pneumatic compression.
compression. What else?
That's it. Oh, we have to do H and H every 6 hours.
Hemoglobin.
Why are you checking her weight?
It's part of the mnemonic. They just check for the weight. Let's do echo check too. Let's consult GI. It's important.
Let's counsel the patient. We didn't counsel the last patient.
Yeah. We'll do that in the 2 minute screen. I think we have time.
Oh, okay, okay. We have a lot of time left in this case.
This one?
Yeah, like we only use 10 minutes and we're done. So you don't have to wait for the 2 minute screen.
Yeah, but it's a 20-minute case usually. This one.
Well, in reality, it will end if you do everything right.
Yeah, you're right.
So here, like, it's not even a real case. You're using a different, so it's not gonna end.
Yeah. But let's finish the important vital stuff first. So now let's just consult gastro and let's do consult. Okay. So what do you want to consult her on?
We're gonna do colonoscopy, DEXA, mammo, pneumococcal vaccine, influenza vaccine,
No,
all that stuff.
counseling now.
Medication. I don't know. What would I counsel her on?
So non-steroidal. Yeah, that's about it.
What did you do?
We will do no non-steroidal for now.
Mm-hmm.
So now we'll the screening we'll do it in the 2 minutes, not now. It's not important right now. Let's just take care of her right now. So now the after 2 units of transfusion, let's just check her out because we put the hemoglobin and hematocrit every 6 hours. Let's check how she's doing right now. Okay, so now her hemoglobin is 8.5, which is good.
Mm-hmm.
I would want to do colonoscopy here.
Sure. And the ED?
She's in the ICU now.
I'm in ICU.
Yeah, let's give her polyethylene glycol. You know what is that for, right?
That's a prep for colonoscopy.
Yeah.
Why are you gonna make the poor person go through this while she's in ICU? If she's in ICU, she's not considered
because
stable.
she feel better now and her bleeding stopped. So
So I would give her some time and do a colonoscopy maybe next week, or maybe not next week, but like in next day or something,
okay,
or
we
like
can we can wait for next day. No.
now. If you think about it, she's in ICU. She just got RBCs. She's probably like not fit for a prep. So she's gonna lose a lot of fluid if you give her the prep.
Yeah,
Or
yeah, you're right. Yeah,
colonoscopy.
yeah. Now I'm assuming that she's feeling better and
Okay,
everything.
like we should give her a few days. Like maybe we can discharge her, tell her to come back in like 2 days for the with the prep. That's not gonna do anything.
Okay, you want to shift her to inpatient and do that? Let's do that then.
I think that's better, yeah. Because if she's stable, we should move her to inpatient and then we can do it,
Yeah,
yes.
let's do this for the. What happened? Ouch. Okay. So polyethylene glycol. Okay, colonoscopy. Now let's just get the results.
Mm-hmm.
Okay, so the colonoscopy is showing multiple diverticular sigmoid and descending colon and two small 4 mm polyps seen in the sigmoid colon.
Mm-hmm.
Biopsy are taken. Now, since she's feeling better,
Mm-hmm.
let's just discontinue NPO.
Mm-hmm.
What else do you want to discontinue? Discontinue IVXS.
Um,
Omeprazole. Let's give her diet.
mm,
What diet do you want to give her?
I guess normal.
Clear liquid diet.
Food restricted diet?
Hmm. Let's see. Full liquid. Full liquid diet. And let's give her high fiber diet too. And just put hemoglobin every. It's already every 12 hours, so that's okay.
What
Okay,
did you say?
now.
Okay.
Now let's just monitor her every day, right? Just see how she's doing. Now she's feeling better, so what do you do? What do you want to do? Her hemoglobin is fine, everything is fine.
Discharge her?
Yeah, excellent. So just let's discontinue some of the stuff. Discontinue that. We don't need that. We don't need that.
Saline.
Mm,
Oxygen.
no, keep that. Discontinue that. Discontinue. Um, let's just discharge her home now. Just follow up in 1 week, and we'll check her hemoglobin in the next visit.
Mm-hmm.
Okay, now she's again here. Let's check her hemoglobin.
Mm-hmm.
CBC, CMP. Follow up with her in the next. Okay, now we did our stuff. She's 65 now. Now go ahead. What do you want to do? Colonoscopy?
Mammo.
Mama?
Dexa.
Dexa, okay. Vaccine.
Pneumococcal.
Yeah.
But do it at a later date.
Yeah. Schedule it later.
But didn't she just get a colonoscopy? Why would we do it again?
Yeah, you're right. I'm gonna cancel that. That was stupid, yeah. Yeah. Influenza. Do you want to give her anything else?
Mm-mm. I think she's fine.
You give her later, that's okay. Cancer colonoscopy. Yeah, I think that should be fine. Okay, so this is a very good case. Like it's a lower GI bleed.
Mm-hmm.
So how do you summarize? So just to give you a hint. So the lower GI bleed. When do you? What's definition of lower GI bleed?
What's the definition? It's bright red blood.
Yeah, when it's below the ligament of treats, that we consider lower GI bleed,
Mm-hmm.
and if it's above, that's an upper GI bleed.
Oh, okay.
Okay, so how would you summarize this case?
Um, so basically we have an unstable patient who comes in with a bright red blood per rectum, and we should automatically have a lower GI bleed causes of that in our differential, and we should do a workup according to that. So we're gonna stabilize her with fluids. We're gonna keep her NPO. We're gonna do NG tube. We're gonna make sure that she's not bleeding from GI, upper GI. So we have to rule that out too. And we are going to stabilize her and see check her H&H. Once we get her H&H back, if she is less than 7 hemoglobin, we need to transfuse her. So we are therefore going to check her PT, PTT, INR, type and screen, and then give her the blood, pack RBCs. Once that, we're going to check her again every 6 hours to make sure her hemoglobin is coming up. Once it comes up, she stabilizes, we move her to ICU. In ICU, we monitor her very closely, and once she feels stable and she says she's fine, we move her to ward. Once we move her to the ward, we want to order a colonoscopy on her. We want to make sure we know what the cause of the bleeding was. And in her case, it was polyps, right?
Yeah.
So we remove, we send for biopsy, and once she stabilizes, we send her home. We tell her to come back in a week, and then we follow up on blood on her H&H, and I think that's it.
Okay, excellent. Yeah. So most cases of bright red blood per rectum is due to lower GI bleed, but
Mm-hmm.
10% is due to massive upper GI bleed.
Mm-hmm.
That's how you.
That means it goes through so fast that it doesn't get black. It gets bright.
Yeah. So how do you differentiate between that, between upper and lower GI bleed in this case? So the B1 over creatinine, if it's more than 20 over 1, that's an upper. If it's less than that, that's a lower.
Mm.
Okay, and you can even perform NG tube lavage to differentiate between the two. What if you found coffee, ground material, or bright red blood in the lavage?
It's an upper GI bleed.
Yeah. How about if you found bilious non-bloody fluid? This means there's no active bleeding if in the NG tube.
Yeah.
So there are four causes of lower GI bleed: anatomic, vascular, and inflammatory, and tumors. Okay.
Hmm.
The the anatomic is the diverticulosis, vascular angiodysplasia, ischemia, inflammatory infections, and tumors can cause that. Okay.
Hmm. Mm-hmm.
So the risk factor could be someone using antiplatelet, anticoagulant. You should discontinue that. So you gotta watch out for that. If someone taking painless bleeding, such as diverticulosis, abdominal pain, change in bowel habit, are important. And this, like if the patient have a change in bowel habit and abdominal pain and lower GI bleed, this suggests underlying disorder.
Oh, we should have advised her high fiber diet.
Yeah, yeah. I ordered the high fiber diet. Yeah,
Oh, you did? Okay.
yeah. Okay. And hemoglobin monitored, like you said, 4 to 8 hours, depending of the severity of the bleed. Okay. Unlike this is very important difference between upper GI bleed and lower GI bleed. Lower GI bleed have normal B1 over creatinine, but upper GI bleed has increased B1 over creatinine.
So lower GI bleed has normal BU and creatinine ratio?
Yeah.
Oh, I didn't know that. Okay.
Yeah.
Well, it
So
makes sense because you lose massive blood from upper, and the more blood you lose, the less your kidneys tend to get ischemic.
yeah, exactly. Yeah, you're
And
right.
they sense blood loss. So they are going to compensate for that. So which makes sense, yeah.
Yeah, you're right. Yeah. So this is like same as with upper GI bleed. You start them with
Mm-hmm,
IV fluid, and
mm-hmm,
the transfusion is the same. If it's low risk patient, you wait. If it's less than 7, then you order transfusion. If it's a coronary artery disease, if it's less than 9, you order. If someone hemodynamic instability even after the IV fluid, then you transfuse him with RBC.
mm-hmm,
Okay, and the GI consultation is recommended for any acute lower GI bleed. Surgical
mm-hmm,
or interventional radiology department should also
mm-hmm,
be consulted for massive bleeding.
mm-hmm,
And anyone with shock, we admit him to ICU, like this patient.
mm-hmm.
Okay, but the
Yep,
other ones, we put them in the inpatient,
yep.
and you gotta put them on EKG monitoring.
Oh, yes,
Yeah.
definitely.
So once you exclude upper GI bleed, what do you do after that?
Um, Once we exclude the snapper, and we know then it's lower, we do colonoscopy, no?
Excellent. We do colonoscopy. Yeah. Good job. Yeah.
Mm-hmm,
Yeah. You have a really good medical knowledge. That's good. Yeah. So that's what our job. We look at upper. If it's not upper, then we do colonoscopy.
mm-hmm.
And usually the upper GI bleed present with lightheadedness more likely than the
Yeah,
lower GI bleed
yeah.
because it's a more bigger loss of blood.
Blood loss,
More
yeah.
yeah, it's more blood. So if the colonoscope is negative, what do you do with upper lower GI bleed?
If the colonoscopy is negative, I'll probably like monitor the patient.
Yeah,
Like,
that's a 250 question. That's a so when you know it, you get 250. So if the colonoscope is negative with lower GI bleed, then you do tagged red blood cells scan, radionuclide imaging study, or you can do angiography.
oh, MRA, like,
Yeah,
oh, yeah, because it could be ischemic colitis, mesenteric ischemia.
yeah,
Yeah.
yeah, yeah. You're right. Yeah. Let me just a second.